so please do fill this in to inform future events. So I would now like to hand you over to Professor Helen Odell-Miller, and the Director of the Cambridge Institute for Music Therapy Research.
Hello, good evening everybody, and welcome from wherever you are, and hoping your weather isn't too stormy and that you're all keeping well. And a special welcome to new students. We have people starting in February in our university on some courses, and a welcome to colleagues, visitors. And if it's the first time you've come, I'll just let you know that CIMTR, the Cambridge Institute for Music Therapy Research, is dedicated to advancing the understanding of music therapy and its ability to effect positive change on health and human well-being through both qualitative and quantitative research inquiry, and also collaboration and delivery of services. And the research calls on expertise and insight from across sectors and disciplines. And I know that often people who come are not necessarily from the music therapy field. So I'm delighted to welcome you all. We are particularly featuring our areas at the moment on healthy aging and dementia, for which last week we were very happy to receive a Research and Innovation Award called the Queen's Award, which meant that some of the team and some who are speaking tonight went to receive that at St James's Palace. And congratulations to all, and thanks to our participants as well. Also, music therapy and neuroscience is a strong area that we focus on, and the area of stroke and neurorehabilitation and mental health across the whole population, and music therapy links to how it can help, and also focusing on children, young people and families. So I'm delighted tonight to welcome all the speakers who have shown distinguished research and clinical work, and the links are what we're focusing on. So we particularly want to look at the links between people's research and their clinical work. And the idea for this was from Naomi Thompson, who's one of our research assistants and a music therapist in CIMTR. So I'm inviting Naomi just to tell you a bit more about her idea.
Hi, Helen, thank you. Yes, so it came about probably last spring. As a CIMTR team, we were asked to sit down and think about what we'd like to see in this academic year's research lectures. And I created a list, and one of them was, I was curious about how music therapists created different approaches or models to their practice based on their clinical experience in a variety of settings and with different individuals, but also the research that they had done or that they'd been a part of and read about. And how these two, as you said, how they intersect and come together to create different ways of practicing in different settings. So we approached these 5 panelists, and I'm really thrilled that they've agreed to come in and speak and share their knowledge for my benefit and everybody else's. So thank you very much.
Thank you very much, Naomi. And it's a pleasure now to invite everyone to speak. And the way this is going to unfold is you've all seen the abstracts and the information, so I'm leaving it to speakers to introduce themselves, and I'll just say one thing as I introduce each person. And first is Professor Amelia Oldfield, who's Professor Emeritus and one of the founders of music therapy at Anglia Ruskin University. And I'd like to welcome you, Amelia, to the Roundtable. And after 10 minutes from each speaker, then they will have a discussion themselves, and then we'll open up to the audience for discussion, which will be using the Q&A and other chat function. And also the speakers have kindly agreed that you could write to us to ask access to slides that they're going to show, because there's a wealth of information, and we've invited everyone to speak for 10 minutes. So once again, to fit all the work you've done, Amelia, into 10 minutes is a challenge, and thank you so much. Over to you.
Okay, so today am going to talk about music therapy with children and their families, the particular role of live, improvised and interactive music making. I've chosen just this one aspect of my work, partly because during the pandemic, I was supervising a lot of clinical work of music therapists working through Zoom. And I was very impressed with a lot of what I saw and things that I never imagined were possible. But the one thing that wasn't possible was this live, improvised, interactive music making. And this kind of made me feel a bit anxious, I think. And also, I then recently have attended a conference of music therapy with families, and I became aware that, particularly in other countries, quite a number of music therapists don't use improvisation, don't use instruments, and don't have this interactive approach. So I started getting even more anxious and thinking, oh, so why do I think this is so important? So that's why this is what I've chosen to do. So I'm going to start off very soon. Could I change the next slide? In fact, I've missed. Could you go to the next two, the one after that, please? Okay, so I'm going to show you a very short clip. I'm incapable of doing any presentations without showing video. But just before that, I need to put it into context. So this clip has been taken from a recent music therapy documentary film called Operation Syncopation, which is based, first of all, on my PhD between 2000 and 2004. And it's a study of 10 families with young children with autism receiving individual sessions. And we videoed all the sessions and then analyzed 222 half-hour videos. At the end of the session, at the end of the research, I gave each family an excerpt of highlights from their sessions. Then 17 years later, in 2017, we interviewed the families to reflect on the experience, both for the young people and the parents. And a film was made combining excerpts from the original sessions with excerpts of the interviews. So in the clip that I want to show you, you're going to see Mikey's mother, Lucy, the music therapist, Emma, who was the research assistant on the original project and participated in the interviews, and myself in 2017, watching the video of Lucy and Mikey in 2001, actually, and retrospectively discussing the work. So I invite you now to copy this link that you see. It's in this chat if you miss it on the slide, and then to find it and to look for minute 45, 25, and to look for 2.5 minutes. And if you could be very rapid in your finding and looking and come back as soon as you've finished, then I'll still have, I think, 6 minutes to talk, which would be great. See you in 2.5 minutes. So I guess we just wait for 2.5 minutes. I hadn't thought of that. That's what's going to happen. I have seen it a lot, so I'm not going to worry too much at this point.
Naomi, are you able to put the link into the chat?
So we could go to the next slide in the meantime. That will save 1 second.
Okay.
Yes, it's in the chat here for people to find.
Thank you.
Actually, Naomi, it needs to go into everyone. So at the moment, I think only the hosts and panelists can see it. Do you see?
Yeah, we have it now.
Yeah, great, thank you. Perfect.
I think I've got 1 more minute. Is that what other people think? I will, in 1 more minute, I'll just, if we go, we'll go on. I'll just say that if people haven't finished watching it, don't worry, they can always look at it afterwards, or look at it again.
Yeah.
So that we can proceed and I don't waste any time. Somebody who may have just joined, who may not know what we're doing and why we're all sitting in silence. I guess, yeah. If there is anyone who's joined in the last 2 minutes, we're all watching the video from the video clip on the chat. And if you don't have chance to watch it all now, you can watch it perhaps at the end.
Thank you, Amelia.
So I think we should, hopefully everyone should now have seen the 2.5 minute clip. And apologies if you haven't quite finished. Maybe you can watch it again later, or any of the film if you want. So I think the important thing to say here is, thinking about clinical practice, Mikey, like many children with severe autism, was very isolated. And one of the only ways to connect with him right at the beginning was to just follow him wandering around the room with the clarinet. And very gradually, this became something more than just me following, and he would react. And it began to be a dialogue. And then it began to be something where we could also incorporate Mum in the trio, and that's the clip that you just saw. So in the discussion that we have as we're watching the video, Lucy very sensitively remarks upon the fact that she thinks it was the non-verbal aspect of the music making, the slow pace of the music, and the fact that it was simple sounds rather than complicated sounds, which made it possible for Mikey to connect and communicate in a way that he couldn't do with language. So in my clinical practice in general, these types of dialogues, they could have been with any instruments, not just the clarinet and voice. It could have been with the piano or percussion, and they could be incorporated into familiar structures and pieces of music. Often it would be combined with humor, dance, and drama. And also there was always this awareness of the importance of following and initiating, who was following and who was initiating. So thinking, next slide, please, thinking about the influence of research. I think, first of all, the research showed that we were able to achieve the objectives. And this was important because it validated the fact that I was having an approach that seemed to be working. And this aspect of the work was central to it. I also was able to find out that I was very active, and I spent a lot of time vocalizing, which was interesting to me. And it was important in the follow-up project that the parents remembered enjoying the sessions and felt that their child was accepted for what they were. Some parents wondered whether I should have directed them more. And this was something I then incorporated more in my clinical practice, making sure I incorporated analyses of videos into the music therapy practice. And that also allowed me to analyze a little bit with the parents how these interactive improvised dialogues were occurring and what they were for. So finally, last slide, please. So in conclusion, why is this important, this aspect of the work? Well, in the first instance, it's sometimes the only way to connect, and it's sometimes the only way and a new way, a way that hasn't been tried before. It often can be a motivating, playful, and non-threatening way of communicating. And I can tailor the music making towards each child's strengths and weaknesses. And very importantly, I think music therapists are or should be uniquely and specially trained to do this. So that's a very important aspect. The musical interactions can easily incorporate and engage parents and provide a positive opportunity for playful interactions, taking account of the parents' musical strengths and the parents' musical tastes as well. So that's where I'm going to finish. I've tried to find these things which help me feel that, yes, this is important and this is why. Thank you.
Thank you so much, Amelia. So we'll hold those thoughts in mind for the discussion. And I'm now very pleased to introduce Dr. Claire Flower, who works with us at ARU on Together in Sound, a project between an ARU, Anglia Ruskin University and Saffron Hall Trust. And her main work is also, congratulations to Claire, who's just become a consultant music therapist in the NHS Trust, Chelsea and Westminster Hospital, London, who's also going to continue the themes, some of the themes, and welcome, Claire.
I've done that terrible thing of sharing my screen and then not being able to find my unmute button. So here we go. Here we go. So lovely to be here with everybody this evening. I'm thinking particularly about how research and practice intertwine as we develop music therapy approaches and the shapes that that intertwining can take. So I'm thinking, and I've titled this really, Practicing Research and Researching Practice. And I'm speaking from a particular context, a child development service for young children with developmental and complex needs in London. And one of our music therapy rooms is there, just a picture for you. So it was questions about practice in this setting that led to my doctoral research. Everyday work here, pre-pandemic, involved parents not only being present in music therapy with their young child, but being actively involved. As a practitioner and a trainer, the how question bugged me. How, when so much literature and training focuses on the therapist-child dyad, how do we navigate the three when a parent is or carer is present? Who did what and how in working therapeutically with a child in this way? So practice for me directly led me into research. And I'll just say a little bit about that research. It was a qualitative practice-based study which investigated those how questions, both through the micro lens of a single session and more broadly across what the sociologist Tim Ingold terms the meshwork of everyday home life, people and places. I argued for an ecological attitude, a shifting approach to practice which considered the 30 minutes or so per week of the music therapy session in relation to the hours of often unknown activity of child and family at home. And I framed this as the meshwork. So if I just show you, doesn't want to click on, there we go. So this is a image taken from one of Tim Ingold's books. At the top is the meshwork, you can see, and at the bottom is he makes the meshwork distinct from what he calls the network. The network, the one at the bottom, much neater, but it's quite often concerned with the points where lines meet and what happens there. Ingold is more interested in the messiness of lines interweaving, coming in and out of contact with each other. The meshwork, as he says here, is the trails along which life is lived, and it offered a helpful approach to understanding the complexity of music therapy with a child and parent. In preparation for this event tonight, the group of speakers had a discussion last week about language such as models, approaches, manuals, frameworks, and any number of other words that we use when we try and gather practices together. So I proposed the meshwork in my thesis as a way of conceptualising the interweaving practices through which music therapy with a child and a parent appears, an approach more than a model. And that's not to impose theoretical form on practices, but rather to allow theory and practice to be reciprocally influencing. I might propose that if music therapy is understood, as Gary Ansdell says, to work in the way that music itself works, then perhaps music therapy theory needs to work in the way that music therapy itself works. So back to practice. This research confirmed the hunches of what we knew as a group of practitioners in the service, that parents and children are often creative, resourceful, and great at expertising together. And it opened up new thinking. It challenged an approach which privileged the work in the therapy room, and it demanded that as therapists we were more interested and took as our starting point what families did at home. Then COVID appeared, and with it, for us as for everyone, a swift move, a swift change in practice, and a swift move to online working with families. Suddenly, practice was absolutely, the work of parents and carers was absolutely vital. And the imperative for us to listen to and work even more closely with parents was strong, asking, how can I help you? Or perhaps even, can I help you at this time? A theoretical model or a tool, perhaps, the meshwork and ecological attitude immediately underpinned our responses as a service. So alongside individual sessions and workshops for parents online, parents told us that they now had perhaps more time to play with their children when they were at home in lockdowns, but not necessarily the resources. So a funding opportunity, which was eagerly seized on by Louise Brown, who was working in our team at the time, led to the development of Sing and Shake kits. Here we go. Kits which included musical instruments and also resource cards, each with a separate activity or song on them. And on each card was a QR code which linked to a short video of a therapist doing that activity. Really down to earth practical stuff. So how then to intertwine this rapidly changing practice with research, and to do that in a manageable and appropriate way given the pressures that all were under? We work to make practice and our research work closely together, making our investigation proportionate and simple, working out what we wanted to ask based on what parents had told us. Some had said that practical resources would enable them to play more with their children. So we wanted to ask whether and how that happened. And some people told us they didn't always feel they knew enough or felt confident enough in their own sitting room at home to just have a go. So we asked them about what difference having a kit made to their confidence. Trying to find congruence, I think, between a rapidly developed practice and an investigative approach. And we kept it simple through the use of SurveyMonkey. When parents were given a kit, which was free, they were asked if they would just respond to a simple 3-question survey, both at the point when they were given the kit, at the 6-week point, and at a later 12-week point. And we've been able to work through the material that's come from parents, with particular interest, I think, now being in the shared play with siblings that's emerged as part of the meshwork, if you like, as well as the intentional uses that parents and carers make of the kits in everyday life. There's more on that to come. If you're going to the European Conference in Edinburgh, you may well hear more about Sing and Shake. One more thing to say though about practicing research, which is to extend the meshwork further and to work with partners to develop and carry through projects. Through conversations, Juliet Wood, who's on the call, the team lead for music therapy, found her way to an academic partner with an interest in music and autism. This enabled collaboration. between PhD students and the service in investigating experiences of online music therapy. And that's a continuing piece of work, bringing with it lively discussions and tussles over academic and healthcare processes, language and priorities. And if that collaboration can happen across institutions and disciplines, then how might that look within the music therapy profession? If we can think about intertwining practice, research and training more fully. So in conclusion, practicing research, researching practice. I've been talking from a context-specific basis, and perhaps for some people in the audience, this sounds too local, too small scale to be useful. Maybe, but it's about an attitude to research that starts local, that starts from practice, and that seeks to ask questions of practice in a way that is congruent with that practice. And in time might grow bigger, but only if that suits the questions being asked and the people doing the asking. So I hope this adds to the conversation. As Ingold says, drawn threads invariably leave trailing ends that will, in their turn, be drawn into other knots with other threads. I'm very happy to stop now and trail some threads. Thank you.
Thank you so much, Claire. And I'm taking away reciprocity between theory and practice. And also the idea of the kits that emerge through lockdown, which I've heard of so many examples of those sorts of kits, and the fact you've researched it, which I didn't know. I'm just grateful. Thank you very much for that inspiring presentation. And now I have great pleasure in welcoming Dr. Stella Compton Dickinson, also linked to ARU in that she undertook her PhD with us here, but who held the position of Head of Arts Therapies and Clinical Research Lead in Nottinghamshire Healthcare NHS Trust for many years. And Stella, welcome to you. Thank you. Over to you.
Thank you, everyone. It's an interesting experience to speak to people that we can't see and can't hear, so it's good to be with colleagues here. And thank you for the opportunity to give a brief overview of what is actually over 15 years of work with my team. So we started with what we call practice-based evidence, as defined by Margus and Evans et al., on learning from the patient, and indeed looking towards a context-specific form of music therapy for patients at the other end, as it were, in a high security hospital. They have severe mental illness and have committed offences. So we followed Medical Research Council guidance for developing a complex intervention, and that began phase 1 with a series of evaluated single case studies, and to test an underlying theory or model in which music therapy was acceptable to all stakeholders. So cognitive analytic therapy is well evidenced and popular in the NHS. The most important thing is cognitive analytic music therapy, the jointly created dialogical activity, primarily in musical improvisation. And so I'll go on to the next slide. Phase 2 was the modelling stage, in which myself and Victoria Slight did a 2-year project to develop the model to a group work model, which would be more cost effective than individual work. And patients were more able to self-reflect after improvisation. So this within the group was where we would together do collaborative mapping of what are called in forensic psychiatric treatment sudden self-state switches between often a victim and perpetrator state, what many of the men in the study called the pit of hell depressed states. So there are many of these states that can suddenly change. This enabled a visual recognition of the relational patterns that we could see and witness in the music, and that is published in this book along with some other things. On we go. Phase 3, moving from practice-based evidence to evidence-based practice, was testing for efficacy. And this was a pilot project with women in a medium secure unit. It involved a lot of stakeholder involvement and acceptance to negotiate funding for my secondment there. And they wanted a model of music therapy that was compatible within an overarching multidisciplinary treatment approach of dialectical behavioural therapy. It was a 12-week implementation. Again, this is published in the same book that I've just shown you. And on completion, we're able to move to thinking about how to develop the methodology for the high secure hospital. This, a single site, mixed methods, patient choice, randomized control feasibility study. I wrote protocols for every aspect, liaising with all the multidisciplinary teams. We recruited and trained a research team who was still delivering services. The 2 music therapists had a 2-day training in cognitive analytic principles, and I trained nurse and team members to administer the outcome measures. Spent a long time developing the semi-structured interviews and observation, and we secured funding for a 2-year implementation, ethical approval having been granted from the Integrated Research Application System and the local Research Ethics Committee. Then we recruited across 5 wards. The implementation has 4 stages. The senior statistician randomized patients who still had to attend all their multidisciplinary treatment to the treatment arm, which consisted of 2 music therapy groups, or to the control arm. So each music therapist ran a once-weekly group of 90 minutes over 16 sessions. The research team delivered outcome measures, and for treatment adherence, there was weekly clinical supervision for the 2 music therapists. There have been 3 iterations of the research treatment manual to create a postdoctoral published guide for future clinical practice, and we hope for future studies. So, mixed methods evaluation, 5 standardized fit for purpose measures. We explored patient satisfaction. It was the first study, it has been the first study to explore comorbidity of patients with very serious mental illness and personality disorder, primarily looking at changes in relating to others, also measuring changes in empathy, which I correlated with changes in dissociative traits, the 2 opposites. We measured sustainability of treatment effect at 8-week follow-up and progress towards escalated discharge at 2-year follow-up, including context-specific external outcome measure. That was another novel aspect at the time to mitigate the Hawthorne effect that was delivered online by, on the ward by nurses. And the next one, treatment effects of cognitive analytic music therapy. Those receiving the intervention developed self-awareness. There was reduced impulsivity. There were no risk incidents for those in the treatment arm, and there were several for those in the control arm. It built reflective capacity and new relational strategies in response to what I now call traumagenic stimuli, understanding psychosis in a different way, and risk reduction. Within the quantitative statistical analysis, there was significant reductions in intrusive and possessive behaviours, which can be so dangerous. Fear of separation and abandonment, usually coming from very ambivalent and anxious attachment in childhood. Sustainable treatment was measured at 8-week follow-up. They were still in hospital then, the patients, for those in the treatment arm. I think I just missed a bit then, didn't I? No, I didn't. We're all right. Okay. Yes. Have I done that one? No, I haven't. This is the next slide. So yes, the semi-structured interviews, that was 2 years of work post-implementation. I had an independent rater with me to challenge me in how I was refining and funneling the data, and we used interpretive phenomenological analysis for that. I triangulated statistical and qualitative data from the primary outcome measure and all other measures, including client satisfaction, and the rigor has been further validated by independent analysis published in the Nordic Journal. The treatment effects. Oh well, I missed a slide, never mind. These things do go wrong. I've already told you that, so let's go forward. Okay, there's something in the way that I can't quite see. So as regards, let me just do something here so I can see what I'm doing. Okay, so the impact, the summary of the impact, it's an acceptable model in the UK and overseas. It's being used in the Far East as well as other countries. but it's early days yet. It was the first music therapy RCT to be conducted in a UK high security hospital. And the postdoctoral iteration was a collaboration with my colleague Lorraine Hockfort from the Netherlands. So there's 2 models published in that book. The idea of cognitive analytic music therapy is towards safe and evidence-based practice for newly qualified and indeed for experienced music therapists who are working in a setting that's new to them, perhaps initially rather frightening, with traumatized mentally ill patients who may be violent. The active ingredient follows very wonderfully, I think, from what Amelia and Claire have said. The interactions in and the effects of jointly created musical improvisation. Everything in cognitive analytic, that model is about being alongside one's patient, integrating tools and techniques. And we used all standardized, reliable and valid outcome measures, and also developed and used a specific music therapy patient satisfaction Likert scale questionnaire. We've now collected lots of those, so there's a bit more work there to do to enable that to be statistically validated and more widely used. Implications for future practice. There's been an independent analysis by Professor Jolliffe, who's much better at a statistical analysis than I am, with promising results, albeit a small study, in his recently published book, which I highly recommend. So initially, cognitive analytic music therapy is a time-limited model. The whole point is that it's integrated with multidisciplinary treatment. It's for the many rather than the few. It ameliorates negative attachment patterns and separation anxiety. When we're closing the sessions, that's a high risk time for people who have committed offences. It improves distress tolerance by using specific closure techniques which can enable safety for all concerned. And it's very exciting that there is a sustainable treatment effect of follow-up, and for those receiving the intervention, there's been no relapse or readmissions. So its cost and clinically effective indications indicate escalated discharge. If I have time, I'll talk about patients B and S as they contrast so much. The most exciting thing for me is how it proves now there's a generalizability. And one of my supervisees works with very deprived children who are in care and separated from their parents. This early intervention of a structured form of music therapy for them when there isn't a parent there, which is obviously very moving. Well, wouldn't it be nice if we didn't need high secure hospitals anymore? Yeah. The ongoing work, this is my final slide, 2 slides. The next mental health challenge is in my view, in treating psychopathy, what we call the dark triad states. There is already a robust theoretical underpinning that we're using in treating narcissism, and GCAMT has been shown to reduce dissociative traits. So understanding psychopathy is what can keep clinicians in forensic psychiatry settings safe and effective. But when we're thinking about research in enhancing empathy, it can be misused. And on National Holocaust Remembrance Day, there was a very poignant story from an old lady who, as a child, had been in Auschwitz camp. She said she used to look forward to going to see the doctor because he called her my little bird, but then, of course, proceeded to do very cruel experiments on her. And later she discovered he called all the children his little bird. So we have to be very careful about measuring empathy and not naive. And of course, there's a positive impact on society of an internal revision of dysfunctional relational patterns. I believe very much in restorative justice following the retributive justice that happens when patients are incarcerated. Here's the new directions. I'm going to whiz over that slide because there has been a lot of extensive research in forensic psychiatry, and this is my challenge. Why has music therapy been described as a niche area? For me, that felt rather dismissive or uninformed, but perhaps it is a perception of expert, context-specific or fine-tuned. Is it hard or is it inspiring to think about the amelioration of violence through music therapy? Or does fear lead to valued or uninformed judgments and lack of understanding of the impact of childhood abuse on mental health in adulthood? along with all the other changes that can lead to someone committing an offence? And might the therapist be numbed out to reflective thought and openness towards work with these really rewarding but severely disadvantaged patients who have been described, poor things, bottom of the barrel? No one cares about them. It's not fashionable. It's too simple to call them bad rather than ill. And are any music therapists out there not curious about how to formulate the index offence? Because if you are, please get this book here and learn about how exciting it is to be able to do that and make a really positive contribution. So thank you for listening, and to so many of you. I'll stop the screen share now.
Thank you so much, Stella. Such a different area, but very central, and I think much more central than on the side, especially in the climate at the moment. So thank you very much for that presentation and for your work. And we'll move now. I'd like to welcome you, Rachel, Dr. Rachel Darnley-Smith, again back to ARU, who last year chaired our International Women's Day Roundtable that many of you came to. And Rachel is a freelance researcher now, but was working at Roehampton University there and has extensive experience in the NHS. And welcome, Rachel, over to you.
Thank you. Thank you, Helen, and thank you to Naomi for organising this roundtable and inviting me to speak. It has provided me with an opportunity. It's sort of like rather unexpected opportunity to revisit some of my own clinical practice of many years ago. It began in the 1980s when I trained at the Guildhall. And part of the reason for this, it'll unfold, was really to start asking a question in response to the title of the seminar, and the title being The Development of Music Therapy Models, and to think about like where I sat with that. And I found myself asking the question, what is a model of practice, and have I actually used one in my work? And I started looking through lots of models of practice in adult work and adult psychiatry. And what I decided to do was, instead of trying to sort of, try and give you a summary of models, which would be very useful, and there's a lot that's very worthwhile and evidence-based out there now, I decided to talk from a more practical viewpoint. So like many music therapists I've heard speaking about their work in relation to psychoanalytic theory and practice, or what I'm going to call here psychoanalytic thinking, many people talk about how this way of working and thinking, it just makes sense to the work, which is a very broad brush stroke as a first statement. And I thought I would look in this short presentation at how it has made sense to me in my work. And I've gone to three examples, three pieces of writing from psychoanalysis. And I've returned to texts that I wrote and really made a lot of sense to me a long time ago. And I think really shaped what I began to do, and it's sort of infiltrated my practice over many years. And anyway, let's have a look. So this is the first example, and this is from Fuchs and Anthony, their book in 1957. And in particular, Fuchs's group analytic approach. So soon after training, I attended the well-known introduction to group work at the Institute of Group Analysis in London. And I found some of the principles of that approach, both theoretical, listening to lectures, and sitting in a group. I found some of the principles that I learnt to be really helpful, invaluable, and quite transformatory in my work. And this is some of the background to what I was doing at the time. So at the time I was working in long stay adult mental health, as it was in those days, and also in a London probation service. And in my work with in adult mental health care, I've run some very chaotic groups with little support. And this is two ways in which those groups might have been chaotic. Music might be consistently loud, making it hard to hear what individuals were playing, or to make musical sense of the whole. And then also there might be a lot of comings and goings in the room, which as a new clinician I found that really bewildering. I think that's the best word to say. Group members might leave the group and return a few minutes later, or leave the group altogether. This could sometimes lower morale and trust in me as group leader. Or on the other hand, sometimes it could lighten the atmosphere and allow space for others. So here are some of the principles from Fuchs and analysis that I took on board and found enormously helpful. Everything that happens in a group is a potential communication and can be responded to. Things that happen may have both conscious and unconscious meaning at various levels at once. And groups can have life stages, and this means that it's possible to understand what is happening in terms of beginning, middle, and end. For example, someone leaving the room to get a cup of tea may want a cup of tea. They may also want to leave what is happening in the room, the loud dynamic or the chaos of the music and the feelings that are being evoked. They might also resent having been told to come to the group at all, as often patients were. Or they might be responding to some other process in the group, to being new or to the group ending. So that's my first snapshot, if you like, group analysis and infiltrating my music therapy practice. So this is a big jump now from group analysis to Adam Phillips. Following a note from a client who told me that they had tripped over an obstacle and wouldn't be able to come to music therapy anymore, my colleague Alison Leving put me onto the writing of Adam Phillips, who was then newly published. This book was just out then. And this chapter, looking at obstacles. For Phillips, the obstacle, instead of something to be moved out of the way, becomes something of interest and meaning and integral to the process of the work. And therapy is about getting to know the phenomenon of the obstacle, the phenomenon in the work. So, for example, a perseverative playing from a client in one group for many months felt impossible to respond to and to run a group around. The work began to move forwards when I realised that my task as a therapist was to get to know the drumming, instead of just sort of tolerating it or trying to ask the client to stop playing or find a way to sort of negotiate how they played. I realised that my task as the therapist was to actually get to know this drumming and to allow space for my own emotional response to it, rather than to try and set ground rules so that the work could begin, that this was the work. So that's Adam Phillips. And now we move on to Helen Morgan and her work on whiteness, and this paper in 1998, Between Fear and Blindness, the White Therapist and the Black Patient. I first read this paper after a crisis in my work, where I felt like I wasn't understanding my clients. And they seemed to be leaving therapy. I started weekly supervision, such a luxury. I started weekly supervision with a psychoanalytic psychotherapist who was very challenging, especially with regards to issues of race and colour, and from whom I learnt a great deal. Here's some of what I learnt from Morgan. This paper came out about the same time. So Helen Morgan is a white psychoanalytic psychotherapist writing about her experiences of working with Black clients. She writes how power balance between white and Black in this UK society is not symmetrical. It should always be addressed openly with clients. That racism is a pervasive business and it gets into everything and everyone. When we attempt to disassociate ourselves from the phenomena of racism, Morgan writes, I believe this is a denial and another sort of defence, a defence against something ugly we fear in ourselves. So my feeling was that the internal, unacknowledged, unconscious racism of the white therapist, in this case myself, might shut down thinking about the racist experiences of the Black client, my Black clients. And in retrospect, this might have contributed to some of my clients leaving therapy prematurely without letting me know. It is possible that they couldn't find themselves with me or their voice. And these are ongoing challenges about which I'm preparing more detailed reflections. And like Claire has already mentioned, the conference in Edinburgh in the summer, I'm going to be talking about that there. So I got 1 more minute, Helen. Okay, so conclusion. These texts I've just cited as foundational were chosen freely by me. What I've spoken about shouldn't be taken as accurate readings of each text. Rather, the summaries I presented were what I, as an individual clinician, took away. The reading here is subjective and representative of my own process as a therapist. The main take-home message from all these texts has been that the experienced difficulties of the work were the work, and as a clue to the meaning of the work, both in terms of how to respond in music and also how to develop some understanding of the clients I was working with. And models of therapy are essential to the development of good responsive practice in articulating and corroborating our discipline, as we've seen throughout the talks just that have preceded me and Mings that will follow. And what I have been talking about is the ongoing practice, maybe prior to and arising out of models that may ensure music therapy remains responsive and in flux, and maybe what Claire was talking about, local. So the very final slide is just a shout out for the BAPT Podcast interviews hosted by Luke Ansley, which give a fantastic document of practice in the UK at the moment, as well as people talking about their research, and everybody here is represented. Yeah, so that's me. Thank you very much for listening.
Thank you very much. Thank you, Rachel. And already I can hear there's lots of debate going on. I can see there are questions and a lot coming up that you're each referring to each other, but we are going to hold that for a bit longer. But thank you for raising all those points that are really central to the work. And I now have great pleasure in introducing Dr. Ming, who is a postdoctoral research fellow here at Cambridge Institute for Music Therapy Research and lead music therapy researcher for UK charity MHA, which is a large UK set of care homes. And welcome, Ming. It's great to have you here as well. And over to you. Thank you.
Thank you. So bear with me. I'll share my slides. Okay. Okay. Can you all see the slide? Okay. Yeah, that's great. Okay. So we want to focus on what I've been doing for the past few years, and it's about developing a music therapy service in care home settings. And in 2008, I think that was the time I started developing, well, I joined MHA and I was given a task to establish a music therapy service in MHA care homes throughout the country. And at the time, I was probably being very naive. I was thinking that's very easy. We just need some funding. We need to hire and employ music therapists, and we need to deliver one-to-one and group therapy sessions. And that's the job done. But actually, it's never that straightforward, as we understand. But I suppose at the time, I had a series of questions for myself. First of all, I was thinking, well, obviously, I trained as a music therapist, but would the therapy sessions I deliver to care home residents really work, really help them? And if they do help, how do they help? I didn't know the answer. And also, by simply delivering group and one-to-one sessions, would that be enough for the setting? Is that what people need, care homes needs? And I don't know. So how can we develop a service that can really be implemented in care home settings? So that's how then I gradually realized maybe some more research is needed. And in 2013, I started my PhD, and that's the time I came across the UK Medical Research Council's framework for developing and evaluating complex interventions. And the framework has been updated in 2006 and again last year. And together with the National Institute for Health Research, this time they have really highlighted some more kind of important work that we would need to do before we can develop a model or an intervention. So first of all, what is a complex intervention? Well, according to the latest definition, we know that there might be two it's twofold. So one, we need to think about there might be different components interacting with the intervention, and you can think about music therapy sessions. There's a therapist, there's a care home resident, a client. There will be musical instruments, there will be music interactions, there will be other non-verbal verbal interactions. So there are different components. So that's the intervention. But also, the outcomes of this therapy can also be affected or be influenced by the characteristics of the persons receiving music therapy. But there can be other external factors, for example, carers, or maybe the environments in the care home settings, or maybe the care provider, the organization, that can also play a part in affecting the outcomes of this intervention. So just to make it easier to understand, well, I hope, so I'm going to use this kind of graph to show you. So let's say we know the fact that fall prevention is an important task for older people and in care homes as well. And this is what the NICE guideline has told us. But to be able to develop an intervention, let's just pretend we want to develop an intervention, maybe music therapy for fall prevention. We obviously will need to look at the residents. Okay, we need to understand why do they have falls? Is it because they have reduced cognitive ability, for example, reduced spatial awareness? Or is it because when they're walking, they have some problems with their balance, with their muscle weakness? And these are the problems that we need to look at. And obviously, we want a music therapist. In music therapy sessions, we might want to use different musical activities, exercises to stimulate spatial awareness, to maybe train their balance and also to strengthen the muscles. So that's the treatment, all based on the assessment of needs. But we know this is probably not enough. We also know that certain medications like sedatives or anxiolytics, these medications can reduce balance. So people will have fall. And fall, obviously, I forgot to mention, falls can cause hip fractures and increase hospital admissions and reduce life expectancy. So this is an important task. So in a way, we need to, outside of the therapy sessions, we need to reduce the use of these medications that can cause drowsiness. So that means the music therapist might think about how to increase caregivers' awareness of these side effects. But that's probably not enough. The organization also plays a big part. Let's say if MHA didn't want to adopt this therapy, didn't want to put in any policies and procedures to help carers understand how music therapy works, then carers may think that the therapy sessions are just purely about playing some music, having a good time. And in that case, they probably will not listen to the music therapist when they come across some problems, for example, falls, symptom management. They would just think, well, music therapists, they can't help, they can only play music. So organizations' support and management support plays a big part. So as you can see, all these groups of people, they can interact, but also within each group of people, there are different aspects, components we need to think about. So that's why an intervention, if we can cover all these aspects, it's multi-component, it's complex. Now, in the latest model, the latest framework for developing complex interventions highlighted these elements in the middle, so that the orange area you can see. So the previous version already talked about the 4 phases of developing an intervention. So you go through let's say the navy blue boxes, and but they don't follow a linear pathway. Basically, at each phase, you can go back to the previous phase, and then you need to evaluate and decide whether you will move forward to the next phase. So these are the navy blue phases, boxes. But in the middle, the orange bit, the section, are the work that we really need to do. And by doing these things, we will understand the target population better, understand what problems they encounter in their daily life, and also how can we then formulate our intervention to help them. For example, we might, to understand the uncertainties, what the problems are, we might need to do some literature reviews, we might need to use quantitative studies, research, for example, observational study, or qualitative study to understand the problems the target population kind of encounter every day. We will need to talk to the stakeholders, carers, and persons with dementia, and care providers, policymakers, to see their views. And then we can then develop our working theories, kind of thinking about how this theory can work to develop, can inform our intervention, and then modify or refine our medication interventions. But there's another aspect, which is the economic consideration. So whether an intervention is cost effective, that's something we also need to think about. So can the intervention reduce hospital admissions or the need for other healthcare services? So, but because we are focusing on the model, therapeutic model, so I just want to pick one thing because it's just too broad. I wouldn't be able to cover everything. I just want to talk about the theory. So for the service that I've been developing, this is the working theory. So, well, this is not just my belief, it's also through literature review and through a lot of different reading, then I come up with a theory that the quality of care in care homes can be enhanced by increasing caregivers' awareness of residents' remaining cognitive abilities. And how do we, why is that important, obviously? Sorry, I don't know why. Okay, so understanding care home residents' cognitive abilities is important. And how do we do that? Well, obviously through music therapist, carer communication. So that's by thinking about the theory of social learning. And that is really about music therapists having a role in training and supporting caregivers, and caregivers can learn from each other, their attitudes, their behavior, even their emotional reactions can be modified, or they can learn and improve the service. Now, knowing the cognitive abilities of our residents can help us manage their symptoms. For example, if a person can still remember some remote memories about their personal life, thinking about these fond memories. So when they're upset, we might get them to think about these fond memories that might improve their mood, to reduce sadness or reduce agitation or anxiety. But if we know what a person can do rather than can't do, then we can find the right and meaningful activities for them to do in day-to-day life. And also these activities can exercise their remaining abilities. And because of dementia, these abilities will eventually go. So we kind of want to help people access these abilities for as long as possible. And in music therapy, this is what music therapy can stand out, is that we can help health monitoring, because a lot of cognitive abilities are not easily observed in day-to-day life. But with music, we can see a lot of subtle, really also almost undetectable abilities in music. We can see them, we can feed back to the staff team. And if a music therapist notices any reduced ability, any change, for example, a person is no longer to move to the beat, to music, then they might suggest a sign of deterioration. And this deterioration might be caused by the change of medications, or maybe it's infection or any other factors. And then we can feed back to help carers. And if a person's health is changed, then we need to modify our care approach. So this is kind of the theory. So how do we then kind of demonstrate or kind of prove the theory? It would take years, a lot of research studies to get to that final point. So, and we obviously in 2015, as part of my PhD, we did the very first step. It's a very, very tiny step, but it's the beginning of something. So we looked at how we can reduce symptoms by delivering the music therapy treatments, but also to communicate with carers using short video clips from the video sessions. Now, the final slide, I just want to say that was, so 2015, that's the first stage. Now we are moving on to the next stage, and we want to utilize this PhD study, which is Kira's PhD, and we want to look at how the quality of care can be enhanced through music therapy in care homes. So like I said earlier, there are different things that we need to do before we can really prove the theory. So we might need to look at the literature, and we are doing a literature review, finding out the factors that can influence quality of care. And we want to find out the right outcome measures to measure quality of care. And we are forming a stakeholder group so they can guide every step of the research, from literature review up to the intervention, and every process, every step. And also we are going to use quantitative and qualitative data to help us understand how residents' needs are identified and met through music therapy. So this is probably not the end after Kira's PhD. We need to do more. There's so much more we need to do to be able to eventually develop the model. So, but thank you very much. So hopefully that can give you kind of a taste of what we've been trying to do. Thank you.
Thank you so much, Ming, and to all of you. And thank you for reminding us. I always had a thought about feasibility and a response to it, thinking, well, people have been using certain models and treatments for years, but then the NIHR require still a feasibility study if something hasn't had a level of research. And you've reminded us of that, and people may have challenges and thoughts and comments on everything that's been shared. It doesn't feel that we can do all your work justice here. I'm going to kick off the discussion now between the roundtable by just going to Naomi and wondering if you have a sort of opening question or a comment on whether your curiosity has been satisfied because you set this up, you designed it and invited people. So over to you, and then we'll see who wants to jump in. And in the last 10 minutes, we'll address all the questions from the audience. So thank you.
Thank you. It's been so interesting to hear all the different ways that you've approached it, from sort of coming really from a practice-based place, from starting with literature and developing answers to questions you've experienced in practice. And I think for me, it's probably created more and more questions, which maybe is my job to go and work and read and learn more about. So it's been really helpful. Thank you. An opening question. I don't know. I guess it struck me, this thing of models, and as models a helpful thing to create. And I think from some of you that was felt as yes, it was helpful, and maybe others felt perhaps no, that's not a helpful word. So I don't know if that's going off on a tangent, but I think that was something I was struck by, the different feelings around model as a thing in itself, a model of music therapy. Do we want that or not?
Thank you so much. I'm sure that there'll be different responses to that. So anyone want to jump in from the round table speakers first, or any comments to each other that arise?
I think the exciting thing is about the commonalities, and to hear words that I've been certainly using over 15 years: collaboration, reciprocal, dialogue, musical dialogue. And yeah, that's just what I wanted to put in, I think, to start with. And thanks to Rachel for mentioning the issue around white therapists and working with, I've worked with a lot of young Black men. I've got a little story about that, but I won't tell it now.
I'll just say something
Yes.
about models, and I know there's other people on the call as well who I work with currently, or may have worked with as well, who may have other things to say about that in the particular context. I think that's what's so important actually about this, is that it's not abstract. It's not that we really need to be talking from where we are, from the jobs that we're in, from what we're paid to do. And models may be more or less appropriate or relevant or helpful in those different sort of contexts as well. But so I'm definitely not anti-model as such, but in the context that I'm talking about there, it seems that our thinking could become a little static if we think in terms of a model, and it doesn't have to, but I think it can do that. And I think approaches with the language of that being about drawing near, coming close to, that has seemed more helpful. But I think the important thing I'm thinking there is that the context is really crucial.
Yes, thank you for reminding us of that. And I was struck by thinking about the group analytic theories that you mentioned, Rachel, and linking that to many of you talking about how important it is that the whole organisation has to manage the ideas of what's best for the participants or the people that they're caring for, and that sort of group dynamic is really important. You talked about that as well, Ming, at the end. And in some institutions or some settings, unless the people who are managing, or let's say who are in charge of care or who are having care, are really part of the process, then things are not going to really happen to their benefit or to change. And I think that was a theme running through all your presentations, from right from the beginning, from Amelia's also reviewing with the families and then reviewing their own work years later.
Yeah, I just wanted to say just also in response to Claire, because we talked about models when we first met last week, and that was really interesting. And I was very struck by the whole issue of models, as I said, as I started to write and prepare for today. And when I was listening to Anna Maritos's interview, I don't know if Anna is here, but I was listening to her interview with Luke Ansley, and she spoke about strategically using a model and realizing that her service in mental health was, it was under threat. And so she took her team into a way of working, adopting mentalization, which was something that could sort of communicate across disciplines. And there was a lot of research already being done, and it was totally relevant to the practice. And I thought that was very interesting, a strategic use of adopting a model. Just to say that.
I think that's certainly what I've had to do as well, but it does begin. I can remember early in my research going to see one of the people on site that I had to report to about what I was doing and why. And they just said, well, it's just a model, isn't it? And I felt rather offended by that. Just a model. How much work does it take to integrate something that the patients want? That was what we were doing in the pilot project, which the chapter in the forensic music therapy book is actually called Integrated Models for Integrated Care Pathways. It's so that it's the most effective way of them going through stages towards discharge. And as it happened, I did one psychodynamic group on that ward, and it was absolutely a big no-no. And in developing a cognitive analytic approach, I immediately found that I had a language by which multidisciplinary teams, other people thought, oh, she's all right after all. Okay, yeah, I know what she's talking about now. And I think that level of communication is what's needed, because they just don't want you if it's, there's the risk, certainly in forensic psychiatric treatment, of re-traumatizing patients. And so the model has to be appropriate and using, what is best now in how not to re-traumatize people. There's so much research with polyvagal therapy, etc., in how to treat trauma now.
Thank you. Got a couple more minutes between the speakers. If any, Amelia, do you want to come in?
I think I think the context specific thing for me is terribly important, but it's also a kind of openness of mind. I think the thing that really got me kind of panicking or worried was the concept that somehow, because of the limitations of Zoom, we might lose something. We might lose a skill that music therapists have. And the skill, the sort of improvisatory nature of that skill, it's difficult. It's not something that people can do very easily. And it's a hard thing to maintain and to keep working at and to keep up. And I guess there was this feeling in me that, oh, are we going to, because we can't do it, we're going to lose it. And then going to a kind of conference where people were saying, no, I don't teach that. What I teach is a model where you don't use any music, where you just use songs and you don't use any improvisation. And I guess I don't think, I would like to be inclusive and think, yes, these are all things that are really important in our work. But I'm also concerned that this thing, which is this improvisation, is incredibly specialized. It's and it's a skill that as music therapists we have to work on. I mean, in my practice, I had to keep working. I had to keep practicing the instruments so that I could still do it. And that if I didn't, then I'd lose it. And so I think this is where my slight that's where I was coming from, really, to think, okay, well, I think these other things, that all the other aspects of the work are equally important, and all the kind of things within the institutions and fitting in and the multidisciplinary, all those things are really kind of essential and important. And I wouldn't But it's just a feeling that some people might be saying, actually, no, those things aren't important. Because then I think we might lose them. I don't know.
Yes, so sometimes the question is often asked, especially now, about what's the unique aspect of a music therapist in their training. And I think you have just touched on that. And sometimes an answer can be, well, it's responding in the moment and adapting. Responding in the moment, adapting and personalizing the music in that moment with the person. And that, I'm not saying other people here in the audience who haven't got a music therapy training aren't doing that, but I think that is a particularly unique thing that you've centered on. And is that a model? Well, we could keep that question open and go now, because we've got our 10 minutes left, actually 9, and we've got 6 questions so far. And the first one I think I might put to Claire, but anyone can jump in, because it's about from Jenny Robson. My particular interest and question is, how can local practice be shared more widely within the profession? Is it related to training, or is it through articles about how to do and not just research outcomes? And Jenny said, well, maybe both are needed. Maybe you've answered your own question, Jenny, but I don't know. It seemed to arise, it came up after Claire's presentation.
Yeah, I'm Jenny. I think we could have a very interesting conversation about this, actually. How can local practice be shared, and what is it about local practice that might be shared? And is it always a good thing to share local practice? She said. And that I say, actually, I do say that seriously, because that if we are not careful and we develop a model, there's that word again, that we then sort of feel we can just plonk somewhere else without consideration of context and need and what's being asked for in that specific place, then I think I'm cautious about that. I'm very cautious about that, actually. But yes, everything, I mean, what you've written, training articles, the how to, the how not to, conversations and communication. But and then the interesting thing for me is that I've then got the question below, a little bit below, from the anonymous attendee, who's talked about how difficult it is to describe a model. A complex contextual approach to music therapy is more what was described. So and I'm kind of putting the two together in my head a little bit, and and the very real questions of what does that mean for us if we stay too context specific or contextual. You know, do we, as do I in a service, do we as a profession, do we risk being sidelined? Do we risk not having the impact that we might have if we go for the bigger picture? So sorry, I've sort of thrown in quite a lot of things there that other people really might want to pick up on.
But thank you, Claire. And you've moved to another of the questions, so that's great as well. I'm just going to comment that Jenny Robson as well has commented that she's had some very successful improvisatory music therapy on Zoom. And there is also another question, which is what comes first? So Elliot Curtis has asked, maybe everyone wants to comment on this. What comes first, a new music therapy model or the conditions which require one? So that's the other main question. And Kira, you can leap in if there are others. We've sort of grouped. So maybe everyone would want to comment on that. We've got 5 minutes left. Or you may feel you've already addressed it.
I think the context defines how to do it. My service wouldn't have survived if we'd carried on doing it as we'd all been taught to do it, I'm afraid. It really wouldn't. And so it's about slightly Darwinian, I think, in having to survive and think, well, what will work, and asking, finding something that is acceptable, as in the Medical Research Council guidance for developing a complex intervention. It's so complex. In the second book that we wrote, this one, I mean, it defines all the aspects and active ingredients of the model in what was needed. And you can't have patients regressing in, in a potentially very violent, rather, some of the wards, the male wards in a secure hospital, it's a bit, there's always a top dog. Risk management is high on the list. And so you have to be innovative, but you can't go experimenting on patients. You find out what everyone wants, and somehow or other I see that Ming is nodding, so I'd quite like to hear from him, because you worked the updated guidelines. I'll be quiet now.
I just totally agree with what you said. I think that's the question I had when I qualified, and I was thinking, well, could I just implement whatever I've learned from my training course in the care home settings? Would that just be enough? And obviously, I think the answer is probably not, because we still need to continue to understand the problems, the challenges people encounter every day. So it's the target population, but also any other relevant parties, but it can be the settings, the needs of the settings, but also maybe the needs of the provider organizations we also need to consider. So everything, it's all about what people need, and then we try to meet these needs. Yeah.
I've got one final thing to add, and that's, I think people need to think much more about integration. There's plenty of eclecticism, but to really integrate something into a service does mean having all those conversations. And also, I remember from years ago, Helen and I having conversations not to throw out the baby with the bathwater as regards really important concepts that are absolutely vital from psychoanalytic thinking within forensic psychiatry. Folks and how groups work at that deeper level. It's so important, and I think we ignore that at our peril.
I suppose that leads on to, there is a question here that I think would take us probably a year to really, does every disease have a way to treat music therapy? And if the answer is yes, what is it? And I think that is a really important question, though, because there is a debate in music therapy, and it's sort of emerging here in different ways about whether there's a very specific aspect of music therapy that needs to be modelled for each diagnosis or population. And then there are also schools of thought and approaches that have been mentioned that are much more rooted perhaps in other aspects and not linked to disease and population. So maybe everyone would want to have a final comment on that. It'd be because we only have a couple of minutes left, and we actually, by the way, at 7 sort of get it comes to the end and we have to say goodbye, regretfully, because this could be such an interesting debate. Anyone want to comment in the last couple of minutes on the panel?
Well, music's universal, and I think it's very risky to look at it from a disease point of view. Schizophrenia used to be called a disease. It's a disorder. It's mediated through music, and that's exciting.
Thank you. Anyone else? Rachel,
you're on mute.
I was saying that I suppose you need practice, and then you need theory and research about practice. So everything needs everything, and it sort of like goes around in circles. And I wanted to say in response to the thing about like local practices, we can all learn from each other's practice. We all learn from each other's practice, and so local doesn't mean it stays local.
No. Very important last point. There is a comment from Esther Mitchell, and there's a sort of discussion and question and answer emerging. So I'm sure there are ways that people can follow up. And we will attempt, if you write to us, to take up any questions we haven't addressed. And there's lots of thank yous coming. So I'd just like to finish by thanking you all and hand back to Kira. It's been fascinating and really inspiring. And thank you to the audience as well. Over to you, Kira.
Yeah, thank you all so much. Very interesting topics and great work. So thank you very much. Just a reminder to attendees, we will send a survey out once the webinar has finished. So please do fill it in to inform our future events. And finally, please join us for our next roundtable, which is the 21st of March. And that will be looking at music therapy and paediatric neurorehabilitation. So thank you all so much again and have a lovely evening.
Thank you.
Bye now.
You all keep in touch.